as a speaker, I can't be seen. It looks like I'm not, you're not able to see me, but you're able to see the slides. So we'll go ahead. Please excuse us for this problem. Right. So we're starting now. Good evening. I am Dr. Atchyuth Gondada. I work as Senior Consultant and HOD, Intensive Care and Anesthesiology at Apollo Hospitals, Health City, Visakhapatnam. Today, we are going to discuss syndromic approach to tropical fevers. This is a part of series of lectures. Our intensive care team planned every 2 lectures a week, and we'll be dealing with all the tropical fevers. The next speakers, all from our intensive care department, would speak on the tropical fevers which are common in our region. And I'll be dealing with syndromic approach to the tropical fevers. So how are we going to deal with when we come across a patient with fever? So what are tropical fevers? Tropical fevers are fevers which are more common in tropical region. You can see the map here, world map. The part of the earth between the Tropic of Cancer on the north and Tropic of Capricorn on the south, with the equator in between. The area of the earth in between these two horizontal lines is the tropical region, and patients, the fevers are frequent. That is because we are blessed with a lot of nature. It's lots of forests, lots of rain, lots of animals, and lots of birds or pathogens. So we are blessed with a lot. And the negative part of it is we also have to face a lot of infective diseases, not like the majority of the Europe. So grossly, what you can see if you go to a resort or a hilly region is what you see here on the slide. Lots of slides, trees, lots of trees, hills, ups and downs everywhere, clouds on the top and water on the bottom. And then grossly, we have a lot of animals too. And not just these animals, we have smaller animals, which are the insects. Lot of insects which help in positively as a part of their contribution to the environment. Also, the negative side of it, they transmit a lot of infections from patient to patient, and they keep the infection endemic to a particular region. And we see lots of seasonal variations, which is because of the increase and decrease in the number of mosquitoes or insects that transmit these diseases. And as India being mostly the India is in this tropical region, and we come across various types of tropical fevers from top to bottom of India. So you come across fever. So what do you think of? You have a patient with fever from, say, some days or weeks, and then based on the duration of fever, you exclude certain causes and include certain causes of fever, and you take the help of this duration, other parts of the history, like their travel history, or where they live, what do they have as pets, and did they get exposed to patients with some other patients with fevers or similar infections. And all this information you gather as a part of the history taking. And then you do the clinical examination. So when you come across a patient, you think of all the possible causes of fever. Like it can be infective or non-infective. And you try to exclude groups of fevers or individual fever based on the history and clinical examination. So if you look at most common infective diseases, you have dengue on the top with 23%, and strep typhus about 18 to 19%, malaria, pneumonias, meningitis, typhoids, and non-specific diagnosis and other non-infective diseases. You have to think of all these possible causes. And then our India is a big country with a large population, and we have more population than the area of the earth, and we contribute to 18% of the world's population. And you see the list of neglected tropical diseases on the extreme left of the table, and then you have the number of cases globally and what is the percentage of patients contributed from India. Look at various diseases. We are contributing to more than 18% of many diseases. And especially if you look at dengue, you have 53% of the global patient burden coming from India itself. So we are dealing with more than proportionally more patients than our population as far as infective diseases are concerned. So what is the traditional approach when you come across a patient with fever? So you take the history, as I mentioned, travel history, exposure history, and geographical location of the patient. Is this particular patient from an endemic area for a particular disease? And then you look at the duration of symptoms, and if at all we can elicit the possible incubation period, we can classify various diseases into short, intermediate, long, and variable incubation periods. And then we use this information to delete certain diseases from our list of differential diagnosis, and then go for the clinical examination. And in clinical examination, along with the fever, externally you look for the rash, and there are various types of rashes: petechial rash, maculopapular rash, vesiculobullous rash, urticarial rash, erythematous rash. And these types, based on the type of the rash, you can again point your attention to the list of the diseases. And then you look at the other physical findings like lymphadenopathy, hepatomegaly, splenomegaly, and jaundice, and other physical features. And based on the combination of various parts of the history and the physical examination findings, you cut short your list of differentials and narrow it down, and then send for diagnostic workup. And then you you design your treatment, and then admit the patient or not admit the patient, treat the patient as outpatient, and then provide your treatment and follow the patient up. And hopefully majority of the patients would improve, and majority of the patients you would be able to reach some diagnostic conclusions. So what if you're not able to reach any diagnostic conclusions and you're able to give only symptomatic treatment and not able to hit the root cause of the whole problem? Then comes the algorithmic approach for diagnosis and management of critical tropical infections. And this majority of the information that I am presenting now is from the Indian Society of Critical Care Medicine guidelines, which were published in year 2014 after a lot of research. It would be shameful if we don't come across our algorithm when we are dealing with more than 1/3 of the tropical fevers, and all our population is living in tropical region. So that was the basis for ISCCM to work on this particular area of healthcare, and they came up with nice algorithm which would be helpful in simultaneously treating and diagnosing the disease. And this resulted in betterment of outcomes as far as tropical fevers are concerned. So what is this algorithmic approach? So all the fevers are divided into 5 major syndromes, and before dividing the fevers into syndromes, we have the red flag signs with acute undifferentiated febrile illness, indicating need for hospitalization and urgent treatment. I hope you are able to see the slides. Slides can be seen, right? Yeah, I hope you are able to see the slides. And what are the red flag signs here? So if the patient is very weak, not able to stand or walk without support, and there is hyperpyrexia or hypopyrexia, hypothermia, and then there is shortness of breath with respiratory rate of more than 22 per minute. There is cyanosis, arterial saturation less than 92% on room air, and then blood pressure is low, less than 100 millimeters of systolic if the patient is of normal blood pressure, and cold and clammy extremities, and capillary refill time more than 3 seconds. All this would indicate shock. And neurologically, the patient has altered mental status with Glasgow Coma Scale less than 13, or there can be associated convulsions, meningeal signs, and abdominal pain with severe or persistent vomiting, conjunctival or palmar pallor, which would indicate anemia, which could be because of loss of blood or breakdown of blood, jaundice on examination of sclera, petechial or purpuric rash, and bleeding from nose, gums, or venipuncture sites or natural orifices. So these are all the red flag signs which would warrant you to admit your patient into hospital and initiate urgent treatment. So the fevers are differentiated into 5 major syndromes. It can be undifferentiated fever, or fever with rash and thrombocytopenia, or fever with acute respiratory distress syndrome, fever with encephalopathy, and fever with multi-organ dysfunction syndrome. And these are not totally different areas or different types of fever without they're not without any overlap. There is a lot of overlap. You can find a patient with fever, rash, and thrombocytopenia along with respiratory distress, some more organ dysfunction. But to make the job easy and for making us to think in divide and analyze the clinical spectrum, the fevers are divided into 5 major syndromes, as I mentioned before. So what do you do when you come across a patient with fever? So first assess the patient's airway, the routine ABC, and then stabilize the airway, help with breathing, or assess the breathing and circulation, and help with each one one after the other and simultaneously. And SIRS obviously was valid in 2014, and now we don't speak about SIRS, but all these clinical features of pulse more than 110, respiratory rate higher than normal, and hypotension, this would, as we discussed earlier, this would warrant the admission of the patient to hospital, and then you start treatment and then look for the cause simultaneously. So where is the focus of infection? Are you able to point your finger at particular area of the body? Then you would direct the treatment towards that particular area. Like you have pneumonias, pyelonephritis, biliary tract as a source of infection, or cellulitis, or some other thing, and then you would go for appropriate investigations, which also include blood cultures, because fever indicates that there is systemic spread of toxins or the causative organism, and treat and start your treatment, both symptomatic and the root hitting treatment empirically. So that would help, or that would, this particular ability to identify the focus of infection would put your patient in one spectrum of the disease. And if you can't point your finger at one particular part of the body as a focus of infection, then you have to go for the syndromic approach. So you consider the risk factors, geography, and the travel history or social history, which part of the year you are in, and what are the associated symptoms. So based on this, we can put the patient into two broad categories: fever with encephalopathy or fever with the other things, that is rash, thrombocytopenia, jaundice, ARDS, and multi-organ dysfunction syndrome. So what do you do next? So you have patient with let's put the encephalopathy aside and look at the other four features as I mentioned. So now you investigate. So what do you send for investigations? So you take the blood culture. Of course, that's not the first thing to mention, but that is important. That is what they wanted to tell us here. So blood cultures, two sets: total blood counts, complete blood counts, platelets, electrolytes, CRP, creatinine, liver function tests, urine for analysis, and chest X-ray. And also, you would use rapid diagnostic tests for malaria, and then dengue fever, typhoid, H1N1, and if any of these are available. And then for typhoid, you would use rapid diagnostic kit. Also, we would be using malarial smears, that is to reach some causative conclusions. And so based on the rapid tests, if we have suggestions to say that it is malaria, dengue, typhoid, or no information at all, so no useful information. So malaria, what do? You go for artesunate at 2.4 milligram per kg at admission, and then 12 hours and 24 hours, and then once a day. This we all of us know. And then dengue, you have fluids, supportive care for bleeding, and any electrolytes or whatever abnormalities you give the symptomatic treatment. And then comes typhoid. Your rapid diagnostic test tells you that the patient has typhoid, go for ceftriaxone. So this is okay. So you have reached at least some of the diagnostic components. You have etiological diagnosis. That is good. If you don't have etiological diagnosis, what do? Then go for empirical treatment. That is ceftriaxone 100 milligram per kg per day and doxycycline plus or minus azithromycin. And the workup, scrub typhus, dengue, leptospira, and vidal. And also you would go for ultrasound abdomen, bone marrow examination, and cultures. So with this empirical treatment, you would be covering most of the possible etiological factors. Then probably you have to continue the diagnostic workup until you reach the etiological conclusion. Okay, so this is the fever without encephalopathy. So what if the patient has signs of encephalopathy? So you have signs of encephalopathy, you assess the patient like the usual ABC, you check the blood sugar, check the hydration status, and if there is history of seizures, you attend them. If there is hypoglycemia, give him dextrose as a bolus and infusion, or high glycemia, high sugars, you give insulin. And then hydration status, dehydrated, correct it. Normal, you give only maintenance fluids. And seizures, we know we can give antiepileptics. And then the continuum of this flow chart is you take good history and physical examination. And if there are signs of focal neurological deficits or increased intracranial pressure, you would take the patient to one limb of this flow chart. So you give him ICP management protocol, and then control hyperventilation. If patient has hyponatremia, you probably would consider 3% saline, mannitol, and then if you think it is useful, you may give steroids, control fever, and seizures. This is all measures to decrease the intracranial pressure. And then you would also go for neuroimaging, contrast enhanced CT or MRI based on the patient's readiness for MRI, or if you are able to maintain the patient on MRI scanner. And then if there are no focal signs of neurological deficits or any features of raised intracranial pressure, you would consider so that you can take some fluid out and use that CSF for diagnostic purposes. So what would you ask for? The cell counts, protein, glucose, gram stain, latex agglutination, and then Gill-Nielsen stain, Indian ink stain, and viral PCRs for herpes and Japanese encephalitis. So all these things, along with an arterial blood gas, electrolytes, renal and liver function tests, electroencephalography, malaria, anything. If there is suggestive, what we are looking for is the cause. How can we reach the causative diagnosis? So what is the reason for all this, and how can you hit the root cause of this particular problem? So this is what we are doing all this diagnostic workup for, and simultaneously we give symptomatic treatment, supportive care, and presumptive therapy. And then if you are able to achieve some diagnosis, you hit it directly with specific therapy. So you have what do you do? You have fever with thrombocytopenia. That is one of the 5 we discussed. So fever, you give antipyretics for control of fever, and because this would result in loss of fluid loss, either visible or non-visible, so you would give IV fluids. And then not to make it complicated, you would avoid aspirin and anticoagulants. And also you would, because there is thrombocytopenia, and you wouldn't know the threshold for bleeding in terms of platelet counts because it is different for different people, you would be more careful and look for any sign of bleeding. Then dyspnea, shock, and then if the platelet count is less than 20%, or if the patient is clinically bleeding, you would go for platelet transfusion. At this point, there is no role for steroids. And then obviously we go for specific therapy once the etiological diagnosis is established. And coming to the next part, that is fever with jaundice, you would give antipyretics. And then because there is jaundice, there is possibility of bacterial infection, you would empirically go for ceftriaxone 2 grams BD and tablet doxycycline 100 milligrams BD. IV fluids, you would look for any sign of organ failure, that is urine outputs, for kidney, seizures, encephalopathy, or bleeding. And then you would transfuse fresh frozen plasma, cryoprecipitate, and again specific therapy once the etiological diagnosis is established. So fever with renal failure, along with antipyretics, ceftriaxone, doxycycline, IV fluids as per the clinical examination, or the CVP or IVC compressibility. You watch for encephalopathy, bleeding, and then seizures, ARDS, renal replacement therapy. Based on the patient's condition, you would go for intermittent hemodialysis or continuous renal replacement therapy, and then hit the specific cause if the diagnosis is established. Encephalopathy, fever with encephalopathy, yes, antipyretics, ceftriaxone, and then comes acyclovir. If there is encephalopathy, you can go for empirical and acyclovir at a dose of 10 milligram per kg and up to 20 milligram per kg in children intravenously every 8 hours. IV fluids, IV mannitol or 3% saline with for increased ICP, seizures and anti-epileptic drugs if there are seizures, and specific therapy. And then respiratory distress, antipyretics, IV fluids, oxygen supplementation with whatever method available. You can give injections ceftriaxone and injection azithromycin, and then oseltamivir if we are in endemic um, area, or you're in that what do you call, if there is increased possibility of H1N1, you would add oseltamivir also empirically, and you watch for impending respiratory failure, shock, renal failure, alveolar hemorrhage, and hit the root cause once the diagnosis is established. So, and then, so, oh yeah, okay, you have come across a patient, you have identified the red flag signs, admitted the patient, you're treating the patient with all the possible care necessary, and then you're giving supportive care, establishing good rapport with the family, but still the entire situation may not be under your control. Every patient may not respond the way you want him to. So there is possibility of developing secondary infections, or there can be non-infective complications, multi-organ failures, either due to the primary cause or due to the secondary infections, and prolonged hospitalization with each and every complication added. There is morbidity, and we see a lot of patients who needs rehabilitation after simple infective fevers. This again is related to financial burden, either because of loss of their um, 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 the work or employment, and then the expenditure that they have to spend for the treatment, and then risk to life. All these are complications that we can expect after uh, after we come across patients with fevers which are possibly due to tropical fevers, right? So I will stop at this point, and if there are any questions to discuss or any contribution that would add to this, I'm happy to receive. And my subsequent lectures, which will be shared, the links will be shared. My team members will discuss on individual diseases. The next being dengue fever, and that is by Dr. Sai Ramadevi, and we will share the link and we'll inform the time to you so that you can log on and contribute to the discussion. Thank you very much.